Good morning, everyone. Today I would like to talk about the diseases of the orbit. Firstly, regarding the anatomy of the orbit, I would like to divide the orbit into 4 spaces. The most anterior one, the one in blue, is the globe, and then posterior to it we have the V-shaped or triangular muscle cone. We call it muscle cone spaces, and then just internal to it we have intraconal space, the one in pink, and then we have extraconal space, the green spaces outside our outermost spaces. And according to these anatomical spaces, we classify the diseases of the orbit. These are the diseases of the orbit. We can classify, as I mentioned, according to the anatomical sign, and I'm going to pass through all of them in more details in the next few slides. Firstly, we have the disease of the globe. The globe is ovoid shape. It has anterior and posterior chamber, and it is separated by the lens, and it's coated by 3 layers: retina, the innermost, and the choroid and the sclera outermost. These are the diseases which is related to the globe. First, we have retinoblastoma, and we have retinoblastoma mimics, including these 3 diseases. And then we have melanoma, choroid hemangioma, metastasis. And also we have some miscellaneous topics. I'm going to talk about it. First one, we have retinoblastoma. It is the commonest pediatric malignant tumor of the globe. It's derived from neuronal retinal cell, this layer, the retina, the innermost layer. Okay, it's highly malignant, occur in children in less than 3 years old, the child coming or present with the leukocory, as we see in this picture. The most important feature of this tumor is calcification, which is occur in 95%, as we see in the CT scan, and 1/3 of the cases is hereditary, is autosomal dominant. Regarding the radiological feature, they are saying that if CT scan shows a globe mass with calcification in a child less than 3 years old, consider it as a retinoblastoma until proven otherwise. And MRI is important to assess the intracranial extension and or the extension along the optic nerve. This retinoblastoma is highly cellular mass. That's why it appears high in T1, high signal intensity, and low signal intensity in T2, and also shows fluid restriction in DUI and ADC. And some minimal enhancement occur, as we see in this picture, in this tumor. Always is important to take 3 things in retinoblastoma. First one, we have calcification. As you this is MRI showing soft tissue mass containing internal calcification with to check is bilaterality, which is occur in 25%. As you see in this picture, we have to check it always. And don't forget to look at the brain, because sometimes you have extra mass or tumor in the pineal region, pineoblastoma. We call it trilateral, or sometimes in addition to the trilateral, we have another supracellular mass, we call it quadrilateral. The 3rd important thing we have to check in retinoblastoma, it's intracranial extension. As you see in the CT scan MRI, you see this is the retinoblastoma mass and with the extension intracranially, as you see in both pictures. We have retinoblastoma mimics disease, including this disease, persistent hyperplastic primary vitreous, PHPV, and retinopathy of prematurity and cause disease. These 3 diseases has no calcification, and all of them, it is hyperdense in CT scan and hyperintense in sequences of MRI, like T1, T2, and FLAIR. I'm going to talk firstly about the PHPV, which is congenital disease. If you look at this picture, usually during the fetal life, we have the hyaloid artery, which is a branch of ophthalmic artery, coming out from the ophthalmic artery, passing through the hyaloid vessels to passing through the hyaloid canal to supply the lens anteriorly. And usually in 20 weeks gestational age, regression normally occurs in these vessels, but if this has been failed, this will lead to a disease, PHPV, which is giving a martini shape. This is the martini glass, as you see here in all sequences. And this is a Doppler ultrasound showing again the persistence of the vessels, hyaloid artery here in this area. The features of this disease is calcification is not present here. It's always, not always, almost it's unilateral and associated with small eyeball and irregular lens and small lens. Second one, we have retinopathy of prematurity. This is occur acquiredly to a premature baby whom admitted to neonatal intensive care and after prolonged ventilation with a high concentration of O2. So usually in premature baby, the vessels of the retina is not well performed. And when we give high concentration of oxygen, this will lead to stop of the growth of the vessels. And after removing of the oxygen, the growth of the vessels, retinal vessels, trying to catch up the normal growth, and then will lead to over formation or new of the vessels, and bleeding occur, which lead to retinal detachment. The feature of this disease is bilateral usually, and calcification again absent or very rare. And sometimes called retrolental fibroplasia. As you see in this picture, bilateral, small eyeball, hyperdense in CT scan, and this is MRI show bilateral retinopathy of prematurity. Third one, we have cause disease against congenital abnormality in the vessels of the retina will lead to formation or accumulation of cholesterol crystals, as we see here, which lead to retinal detachment. Again, it has no calcification, unilateral, but here the eyeball is normal in size. The previous disease forming leukocory, as you see in this picture. So we have an approach for them. Always check the calcification in the globe. If it's present, think about the retinoblastoma. If it's not, see whether if it's unilateral or bilateral. If it's bilateral, so it's retinopathy of prematurity. If it's unilateral, check whether the eyeball is small or not, the lens is distorted or not. If yes, it's PHPV. If it's no, it's cause disease. So we have an example for this one. Child coming with leukocoria, CT scan has been done for him. As you see in this picture, hyperdense, small eyeball, unilateral, and it is hyperintense in T1 with fat sat and in T2. So this is our approach. There is no calcification, so don't think about retinoblastoma. Think about these groups. If it's it is unilateral and with small eyeball, so think about PHPV. And this is the ultrasound done showing on double color study showing the hyaloid artery. Okay, we have malignant melanoma. It's the most common adult primary intraocular malignancy that arises from the melanocyte of the uvea, this region. Almost always unilaterally. No calcification is there. We said in the retinoblastoma, it's occurring in children and calcification is there, but this one is in adult and no calcification spread. Spread occur beyond the globe, as we see in this picture, giving the color bottom shape, as you see here. Our cottage loaf is an England brand, this shape. It is highly malignant, metastasis to the liver and lungs occur, and causing progressive painless visual loss. Regarding the radiological feature, this is vascular Doppler study. CT scan showing hyperintense, as you see in this picture. Because melanin, it has a paramagnetic effect on MRI, so it shows a high intensity on T1 and low intensity in T2, and also it is enhanced in after gadolinium, of course. Other disease of the globe of the eye, we have choroidal hemangioma. It's benign vascular lesion of the choroid from its name. It is two types, either circumscribed, isolated, or diffused, which is occurring in Sturge-Weber syndrome. It's lenticular, as you see in this picture, densely enhanced because it's highly vascular. So it is densely enhanced, as you see in the Doppler study and after enhancement in MRI. It's less common than retinoblastoma. Ocular metastasis, 50% of the cases, we have unknown primary cancer, either from GIT in male or from lung or breast in female. This is the metastasis to the uveal region. But if there is no known primary cancer, then the diagnosis of the ocular mass is very difficult. So we diagnose it at the normal malignant melanoma, not the metastasis. CT and MRI shows variable morphology, variable intensity, and generally enhancement is there. We have another disease of the globe of the eye, it's drusen disease. This is age-related macular degeneration, accumulation of hyaline material occur on the optic disc bilaterally. It is asymptomatic, incidental finding, or could be symptomatic, lead to headache and visual defect. This is ultrasound showing the calcification of the optic of the disc with posterior shadowing. We have retinal detachment and choroidal detachment. Retinal detachment is the detachment of the retina from the underlying pigment in choroid. As you see, the retina is extended from the optic disc, nicely curved to insert in the ora serrata, while the choroidal detachment or the choroid extend beyond this anatomical level to insert in the ciliary body. That's why when there's a detachment on one of them, so we can differentiate as seen in this picture. This one is the retinal detachment, the landmark or limit at the ora serrata, while in the choroidal detachment is passing this point more anteriorly. As you see this picture, this is the retinal detachment giving a V-shaped or triangular shape, extending from the optic disc to the ora serrata in both sides, while this one is passing the ora serrata, as you see in this picture, and is diverged posteriorly away from the optic disc. This one is on real-time ultrasound. When we examine it, it's freely movement, while this one is more fixed during the examination of ultrasound. We mentioned these pictures are showing the retinal detachment and choroidal detachment in ultrasound and CT scan. We have coloboma vestaviloma. Coloboma is a defect in the eye globe. Okay, usually in fetal life, we have fissures at the origin of the vessels. Sometimes incomplete fusion of this fissure will lead to formation of a defect in the eye globe. All three layers, retina, choroidal, and sclera, will lead to formation of a cystic-like lesion, has a connection with the globe. This is the coloboma in both sides in T1 and T2 MRI section, axial section. And also we have vestaviloma, which is it's like a coloboma, but it's acquired, occurs after inflammatory and degenerative conditions. And the weakness only in outer layer, not all the three layers. As you see, this is the vestaviloma distortion of the eyeball, but there is no cystic or diverticulum-like connection posteriorly. Orbital trauma. Think about the globe rupture if there is a collapsed globe, as you see in this picture, or we call it flat tire. If there's any presence of intraocular gas or foreign body, think about globe rupture. Look at the posterior sclera, it will be thick, hazy outline. All these are features of orbital trauma or globe rupture. This is CT scan coronal section showing herniation of the tissue of the eye after rupture or fracture of the floor of the orbit. We have something we call it ectopia lentis. It's not specific for trauma, but could be present in other systemic diseases or syndromes like Marfan syndrome, homocysteine, urea, and Ehlers-Danlos syndrome. As you see in this ultrasound showing the lens is not in appropriate position, it's ectopic. Also the CT scan showing the lens is not in its normal position if you compare it to the opposite side. We've done with the first space. Now I'm going to talk about the second spaces. It's the muscle cone. The orbital muscle, all of them, except from inferior oblique, apart from it, it's originated from annulus of Zinn and inserted in different part of the eye to form a cone-shaped area. We call it muscle cone, and we have a disease related to these muscles. We have an approach again for that. If the muscle or multiple muscles are involved, so think about thyroid of thermopathy and or acromegaly. If single muscle involved, it's either inflammation or neoplastic 50-50%. So we know that inflammation, it's more like it's painful, more like neoplastic. So painful means inflammation. Most one we have the most common cause we have orbital cytotumor, and in neoplastic again we have either primary or secondary cause. Primary is we have lymphoma and rhabdomyosarcoma. I'm going to talk about one of them in more details. First one, we have thyroid of thermopathy. This is a result from mucopolysaccharide or inflammatory cell deposition in the muscle eye. It's the most common cause of adult exophthalmos, usually bilateral in 85%. This one is important. They are saying it is unrelated to the thyroid function. That means 10% of the thyroid of thermopathy occur in normal TSH. Regarding the radiological feature, It is, as you see, there will be fusiform enlargement of the muscle, sparing the tendon, giving the Coca-Cola bottle sign, as you see in this picture. Also will lead to formation or increased volume of the fat, intraconal fat, and lead to exophthalmos and proptosis. And this also lead to compression of the optic nerve. We have this coronal section showing the involvement of the muscle in order, like the most muscle affected in the thyroid ophthalmopathy is inferior rectus, then followed by the medial rectus, then superior rectus, then lateral rectus, and then superior oblique. So I am slow order. Second disease, we have inflammatory orbital pseudotumor. This is idiopathic inflammatory condition from its name, inflammatory. This is the commonest cause of adult intraorbital painful mass. It's unilateral, painful, most commonly affected the lacrimal gland, and then followed by extraocular muscles. If it's involved the extraocular muscle only, we call it myositis type. And also we have tumefactive type, which is diffuse, involving of the conal and intraconal structures. This one is the diagnosis of exclusion. We should correlate it with the clinical feature, and because always there will be pain. It's involved unilaterally, involve single muscle, okay, and there will be a fat stranding, as you see in this picture, haziness and fat stranding because of the inflammation. This is a good difference between the thyroid eye disease and inflammatory orbital condition. Here it will be painful, painless in thyroid eye disease, while it is painful in the inflammatory condition. This is more common. This is usually bilateral. This is unilateral, affecting any muscle. This is affecting more commonly the inferior rectus and medial rectus muscle. And this one will respond to steroid, while this one is not. Third and final disease of the last disease of the space of the cone. Sorry. Rhabdomyosarcoma. It's highly malignant, occurring in children aged 2 to 5 years old, and more commonly occur in the superior medial area, causing bone destruction. And in CT scan, it is showing aggressive looking, highly enlarged mass, and it's homogeneously enhanced, as you see in these pictures. So this is the mass causing bone destruction here with enhancement and located superior medially. We've done with the second group. Now we are talking about the disease of the intraconal spaces. So internal to the cone space, we have intraconal space, as I mentioned. We have optic nerve here and the fat. The fat also contains vessels, artery, vein, limbs, and other cranial nerves. So we subdivided it. This group subdivided it to the nerve sheath complex and the fat content. And the fat content, as we mentioned, we have diseases related to the nerve, to the vascular, and lymphoma and metastasis. First one, we have optic nerve glioma. It's most common primary optic nerve tumor, occur at the course of the optic pathway. Sorry again. This is the optic pathway. Okay, so we have Dodge classification. That means it's subdividing the optic nerve glioma into 3 stages. Stage 1, prechiasmatic. Stage 2, chiasmatic. Stage 3, post-chiasmatic. As see, this is stage 3 optic nerve glioma. It's post-chiasmatic glioma. In children, it's low grade, and adult is high grade tumor. It may be bilateral. It's the pathognomonic of neurofibromatosis type 1. And we have optic nerve glioma showing fusiform enlargement, as you see in these pictures, CT scan and X-ray section of MRIs. And T2 MRI might show cystic lesion, and it enhances in 50% of the cases. We have another disease of the optic nerve. We call it meningioma. It's arising from arachnoid layer. Second most common primary optic nerve after glioma is occurring neurofibromatosis type 2, not type 1. And the difference between meningioma and glioma, in meningioma, we can see the optic nerve inside, while in glioma, we cannot see the optic nerve inside. Radiological feature of meningioma, we have tubular enlargement, not fusiform enlargement, as the glioma, giving trunk-track appearance, as you see in this picture, or tough knot in coronal section. These are the trunk-track and tough knot appearance. It is highly enhanced and might show calcification, Osteosis and widening of optic canal sometimes occur in the CT scan, we can see it. But it's very important that it's strongly enhanced. Optic neuritis, the third disease of the optic nerve, is inflammation of the optic nerve. That's mean only inflammation, no swelling will be there. Only enhancement occur after gadolinium. As you see in these two pictures, this is enhancement of the optic nerve, left optic nerve, and here as well, there is an enhancement of left optic nerve. Most common cause of the optic neuritis is multiple sclerosis, which is considered in 50 cases. Path-related, again, we subdivided it into ill-defined lesion and well-defined lesion. Ill-defined lesion means inflammatory condition, like orbital cytotumor, while well-defined, we have either black or white. If it's black, cyst means dermoid or epidermoid. If it's white, that means enhancement is there. So the thing is related to vascularity. Cavernous hemangioma. Hemangioma in adult, we call it cavernous hemangioma, while in children, we call it capillary hemangioma. Cavernous hemangioma is the most common primary orbital tumor, which is occurring in this age group. It's a benign vascular tumor. CT shows sharply demarcated and showing calcified phlebolith, which is pathognomonic. In MRI, it is very high in high signal in T2 and avidly enhanced, as you see. This is avidly enhancement after gadolinium. As we mentioned, capillary hemangioma in children, most common orbital tumor of infancy below 1 year of old. Spontaneously, regression should occur in the first few years. It's called strawberry hemangioma because it's red in color and giving the shape of the strawberry. It's ill-defined, irregular, lobulated, showing homogeneous enhancement. Most commonly occur in the eyelid of the baby and or anywhere in the orbit. And the most important feature in MRI, T2 MRI, showing the internal flow voids, as you see in this picture. Orbital hemangioma, orbital venous lymphatic malformation, the second name of it. It's congenital benign vascular malformation of variable venous and lymphatic malformation. It's common in children, involve the whole orbital spaces. In CT scan, it has solid and cystic component. Solid one is represent the venous component, while cystic component, it represents the lymphatic component. So you have venous and lymphatic. Phlebolith also present there, bone remodeling occur, and MRI, the most important thing is showing fluid levels, as we see in this picture. This is ill-defined, poorly marginated, non-capsulated, multi-loculated, cystic and component orbital lesion. This is cystic T2 MRI coronal section showing cystic lesion. Also here, and this is the most pathognomonic feature of orbital lymphangioma, showing fluid level, as you see in this axial section. Venous pharynx, a massively dilated intraconal vein representing venous malformation. It's rare, about 1%, congenital or acquired are the causes, associated with other intracranial vascular malformation. The most important clinical feature is intermittent proptosis. So it's not permanent proptosis. When we do CT scan, we see there is hyperdense intraconal lobulated mass with intense enhancement. Phlebolith is present there. Sometimes it's very small. We cannot see it during the examination. We have to ask the patient to do valsalva maneuver or put the patient on prone position in order to see it. On T2 MRI, it's showing flow voids phenomena because it's vascular. As you see, also it's taking color in the Doppler study. The last vascular-related disease is carotid cavernous fistula. As you know, the orbit will drain the vein to the cavernous sinus by superior and inferior ophthalmic vein. And then the cavernous sinus has internal carotid artery. So if there is oozing of blood or fistula in the internal carotid artery, this leads to increase the pressure inside the cavernous sinus, and this resists the flow of the vein in this direction, will lead to engorgement and tortuous and dilatation of the superior ophthalmic vein, as we see bilateral tortuous engorged superior ophthalmic vein in this picture. Also, this is MRI showing the superior ophthalmic vein engorgement. Also in lateral angiography, we can see the ophthalmic vein enlargement because of the fistula in the cavernous sinus. Neurofibroma or schwannoma is a tumor arising from peripheral nerve sheath. It is most commonly affected the ophthalmic branch, V1 of the trigeminal nerve, eccentric in the orbit. Hyper in MRI. It is difficult to distinguish between both of them, but this one, the schwannoma, is more common, while the neurofibroma occur in neurofibromatosis type 1 and associated with the greater wing sphenotypoplasia. These are a few examples of the neurofibroma and schwannoma, as you see in this pictures, sagittal and axial sections. And this is abducing schwannoma, which is present on the right side, and plexiform neurofibroma with intracranial extension. Lymphoma, it's in the orbit, it's usually B-type, B-cell non-Hodgkin lymphoma. 10 to 50% of the orbital masses, most commonly affect the lacrimal gland. It's present bilaterally, superiorly placed, affecting the superior rectus and levator palpebral muscle. Radiological feature of this, of lymphoma, is hyperdense. It's molding or taking the contour of the eye bilaterally, as we see in this picture, it's bilateral, taking the orbit contour. Present in the superiorly and displacing of the eyeball inferior-medially. Enhancement occur homogeneously, as we see in these pictures and these sections. The disease of the extraconal space. This is the last spaces. I would like to talk about it. The disease of the extraconal spaces consists of the fat and the bony orbit and lacrimal gland. Lacrimal gland, again, we have an approach for that. It's either bilateral or unilateral involvement of the lacrimal gland. If it's unilateral, again, it's either inflammatory or neoplastic, 50-50%. In inflammatory cause, we have pseudotumor or dacryoadenitis. Neoplastic, we have two causes, either benign or malignant. The benign one, we have mixed adenoma and dermoid. And malignant one, we have primary, secondary. Primary, we have the lymphoma, 25% of the cases. While bilateral involvement of lacrimal gland, we have these diseases for causing bilateral affection of the lacrimal gland. Here, a few examples of the lacrimal gland disease. We have Sjögren's syndrome, which is causing bilateral lacrimal gland abnormality, as you see in this picture. Also, we have primary lymphoma, as we said, is 25% of the cases causing unilateral lymphoma affecting the right lacrimal gland in this picture. And we have another example of pleomorphic adenoma, as you see, is highly enhanced, well-defined benign lesion in the lacrimal gland, left lacrimal gland. Dermoid and epidermoid, they are cystic lesion, congenital. As you see, we have epidermoid and dermoid with their appendage. The dermoid, it has sebaceous gland, fat, hair, as you see in this picture. Whenever there is inclusion of the epidermis, it forming epidermoid cyst. Whenever there is congenital inclusion of the dermoid, it forming dermoid cyst. We can differentiate between these two. As we know, as we said, the dermoid has fat, so it is hyperintense in T1, T2, and flare, and we do fat sat or signal drop will be there. While in epidermoid, restricted diffusion is the characteristic feature of epidermoid cyst, and it is hypointense in T1. Here we have some examples. A child coming to you with a swelling in the eye or the orbit. Ultrasound has been done for him. Well, it shows a lesion or a mass-like lesion, soft tissue, well-defined, well-capsulated, heterogeneous, contain internal echoes with texture similar to the subcutaneous fat. If you compare the subcutaneous fat to this one, it's similar echogenicity. So this means it is fat. CT scan has been done for him. It shows calcification, hypodense area, Hounsfield unit in minus, and T1, T2 MRI showing the hyperintense lesion. And if we do fat sat, we will see a drop signal, as you see in this section. Finally, we have orbital infection. Orbital infection, we classify it according to the septum here. As you see, the connective tissue septum, both upper and lower side, which is divided the orbit into the preseptal and postseptal, as we see in this picture. And the infection, if it's present in the preseptal, we call it periorbital cellulitis, or if it's occur posterior to the septum, we call it postseptal infection. If the infection goes through the vessels to the eyeball, we call it endophthalmitis, sorry. Again, if we do CT scan to this patient, we will see fat stranding because it's inflammation process. We have something else, we call it subperiosteal abscess formation. This is occur after ethmoid infection. As you see, this is abscess with marginal enhancement. Also, this is the orbital cellulitis showing inflammation in the area, fat straddling with inflammation and swelling of the eyelid. Retrobulbar metastasis. The metastasis occur either to extraconal or intraconal area. In adult, it's secondary to the carcinoma of the breast. In children, it's secondary to neuroblastoma or sarcoma. CT scan showing contrast enhancements in the lesion. And we can differentiate this from the rhabdomyosarcoma because in retrobulbar metastasis, they have a baseline hyperdensity and lack of invasion to the preceptal compartment, though there will be no invasion to the preceptal region. Here again, some example of retrobulbar metastasis, as you see in this picture. Enhancement is present in the lesion and restricted of effusion on DV. We've done with all spaces, but sometimes you have large mass of the orbit, which covering the all spaces altogether. We have a few differential diagnoses for this. For example, always check the globe. It's identified or not. If it's not identified, think about retinoblastoma, as you see in this picture. If it is, like the globe is identified, it could be lymphangioma, whenever we see the fluid level with cystic component, as you see in this picture, or it could be lymphoma when it is bilateral, taking the contour of the eye, homogeneously enhanced and restricted diffusion is there, as you see in this picture, bilaterally taking the contour of the orbit. Or it could be capillary hemangioma, ill-defined lobulated mass, with signal flow voids in T2 MRI, as you see in this picture. Or it could be plexiform neurofibroma whenever you see calcification and associated feature of neurofibromatosis type 1, as you see in this picture. And this is the references, and thank you.